Hello everyone, my name is Naomi Schumann and I'm a CSPC Program Committee member. On behalf of CSPC, a very warm welcome to everyone. We are about to participate in a very exciting conference session with the code 664, titled Taking Action on Dementia, Building Better Policy Research Communication, organized by the Canadian Consortium on Neurodegeneration in Aging. Please turn off your videos and microphones. Please also note that this session will be recorded, but breakout room discussions will not be recorded. Please don't forget to tweet about your favorite events and panels at the conference using @Science Policy and hashtag CSPC 2020. In the chat box, I will be adding the link to a short survey that should only take a minute or two to fill out. You can fill out this survey at any point in the session. I encourage all of you to please fill out this survey to give CSPC a better understanding and help us prepare panels in the future. Without further ado, I will now pass things over to Inbal Itzhak, who is the moderator of this session.
Welcome and thank you for joining our session. My name is Inbal Itzhak and I'm the Knowledge Translation and Exchange Specialist at the Canadian Consortium on Neurodegeneration in Aging. The magnitude and complexity of the public health challenges Canada is facing today with dementia prevention, diagnosis, treatment, and care call for a proactive approach to building strong and long-lasting government-academia relationships. The goals of this session are to expose academia and government stakeholders to each other's perspective on addressing public health challenges like dementia, and based on a mutual understanding, develop principles for positive and effective government-academia collaboration. This session will start with a 30-minute panel conversation, followed by a 30-minute breakout room activity, in which speakers and participants will be engaged in distilling government-academia collaboration principles. It is my pleasure to introduce to you our panelists today. First, I'd like to welcome Dr. Howard Bergman, who is a professor of family medicine and geriatric medicine at McGill University. Dr. Bergman's work focuses on health services research and policy in aging, chronic disease, and frailty, and on the promotion of primary care. Working collaboratively with several stakeholder groups, he has performed multiple advisory and leadership roles in healthcare reform, strategy, and policy development, including authoring the Quebec Alzheimer Plan and chairing the Canadian Academy of Health Sciences panel for the assessment of evidence and best practices for the development of a Canadian dementia strategy. Welcome, Dr. Bergman. Next, I'd like to welcome Dr. Isabelle Vedel, who is a public health physician and an associate professor in the Department of Family Medicine at McGill University. She's also an investigator at the Lady Davis Institute at the Sir Mortimer B. Davis Jewish General Hospital. Dr. Vedel's research work focuses on health services research and chronic disease management, particularly Alzheimer's or related disorders. Dr. Vedel's research agenda currently includes programs on the implementation, evaluation, and organization of healthcare services for older patients and patients with multiple chronic diseases. She has expertise in health service and policy evaluation research, implementation science, mixed methods research, and complex systematic reviews of the literature. Welcome, Dr. Vedel. Next, I'd like to welcome Dr. Ginny Lane, who is the Senior Strategic Initiatives Consultant at the Community Care Branch of the Saskatchewan Ministry of Health. She's currently leading work related to the evaluation of innovative community long-term care beds and planning for long-term care system capacity to meet the future needs of our population. She's also a registered dietitian and an adjunct professor with the School of Public Health, University of Saskatchewan, with research experience in healthcare. Dr. Lane has worked in a variety of community development and health system settings over the past 20 years. Welcome, Dr. Lane. And last, I'd like to welcome Dr. Pamela Jarrett, who is a geriatrician in the Department of Geriatric Medicine, Horizon Health Network in St. John, New Brunswick, and an associate professor of medicine at Dalhousie and Memorial University. As a geriatrician, Dr. Jarrett has provided care to people with dementia and their families for over 25 years. She has also been involved in medical education in geriatric medicine. She has over 25 years of experience in conducting clinical trials in geriatrics and is currently leading research on dementia assessment, prevention, and care. She served in leadership roles at the Department of Geriatric Medicine in St. John, New Brunswick, West Horizon Health Network, at the Department of Health in New Brunswick, and in many committees within the Health Authority, government, and the New Brunswick Medical Society. Welcome, Dr. Jarrett. So to start us off, I would like to ask you, as researchers and government officials, what are your expectations of collaborating with each other? In other words, what would be a meaningful engagement of government in research and a meaningful engagement of researchers in policy making? And I invite you to provide as much as possible concrete examples from your work around dementia and aging. Ginny, would you like to start?
Sure, thanks, Inbal. So I'd like to, first of all, outline a bit of one of our successful projects in Saskatchewan, the RADAR project. And so this involves a successful collaboration between the University of Saskatchewan and the Government of Saskatchewan, the Ministry of Health. And so through that project, there are researchers at the U of S that engage in research related to dementia and how to provide community-based assessments and assessments for those who live in remote locations and more complicated assessments. And I think it's been very successful because we have a long-term type of engagement. It's more of a partnership. It's not coming to us every once in a while when we have some request, but it's more of a long-term engagement, and that's why it's very successful. So they have an annual type of an event that they always invite members from the Ministry of Health to, that provides a chance to provide updates from various researchers who work in the area of dementia. And it's a very successful engagement in terms of both sides. So part of this long-term engagement involves, we have an annual grant that goes to the RADAR team. It's not that big, but it's annual, meaning that it's a stable source of funding for them to at least have a skeleton type of staff that can always be stable to provide some continuity to their work. And I believe that's one of the successful reasons for why this partnership works, is we have ongoing reasons for engagement. And, we're always in contact. And it leads to, when we think of something that we have a question about, we know who to talk to about that. And, when they see an area that could be an opening area for doing something different, they know who their contacts are as well. And so just having that ongoing engagement is very helpful to successful collaboration.
Thank you. So this ongoing connection, it's a relationship. Isabelle, would you like to comment a little bit from the research side on this question?
Yeah, thank you, Inbal. So I completely agree with Ginny that the long-term relationship is really important in this type of collaboration. And as health service researcher, what we want is really that our research to be useful and used in practice and policy. But the question is really how to make it useful, And one key aspect is to derive research questions from the field, from stakeholders, from policymakers. For instance, we run a big grant on the impact of COVID for persons living with dementia within the Canadian Consortium on Neurodegeneration and Aging. And the question we receive from government officials, from clinicians, from person living with dementia and their care partner is really how to manage the pandemic, how to protect one of the most vulnerable group of population. What are the long-term impact of this pandemic? For instance, the question that decision maker had in mind is with regard to the increased mortality and the huge wave of death we experienced, unfortunately, in long-term care in particular, are these people who died the one who would have died, whatever, in the following 2-3 weeks, 1 or 2 months? Or are they people who would have a good life for an additional 2, 3, 5 years? So that's the type of question we grab from the field, from policymakers, and then so we start developing the partnership from the very beginning, from really developing the research question together. And we have fantastic tools in research to do that. So for instance, participatory research, where it's a long-term relationship with decision makers, policy makers, clinicians, person living with dementia, care partners, in developing the research question, but as well talking about the method and the timeline and when to provide results and where to publish results. And so that's the main aspect for me for the collaboration.
Thank you. Pam, would you like to add and maybe you can say a word about your unique perspective because you've been sort of on all sides and as a clinician as well.
Sure, thank you. I agree completely with what everyone is saying, and I think the key words in this is meaningful communication and collaboration and aligning priorities. And as Inbal said, you know, I'm a clinician, a geriatrician, but also have been involved with research for many years. And then over the last 5 in the Department of Health in New Brunswick. So it brings the 3 perspectives to the table. And I think that all 3 are incredibly valuable because sometimes policy doesn't always align with what will be picked up practically in the clinical environment. So I think that absolutely meaningful engagement with the researchers and government with inclusion of leaders in clinical care who are going to actually help you translate what's learned in a meaningful way and help with the uptake of the knowledge that's gained. I think that continuing to work together will make a huge difference. And I've been involved with Howard and Isabelle for the last few years on one of the projects through the Canadian Consortium of Neurodegeneration and Aging around how to improve the care experience for dementia patients and their families and carers in the primary care environment. And it's a very complex piece of work, starting off with how many people does this affect? How are they connected to our systems? What is their natural history of their disease progression? What are the things that have meaning to them? And trying to put into that, and what can our policies and our government initiatives do to help allow this journey to be healthy and experience the best way forward for all involved. And I think that the practical approach that CCNA and the Rosa Group has taken to this adds knowledge to the government, to policymakers, but is now kind of at the steps of creating knowledge that will be able to be translated clinically to really be important for patients and families so that there's a noticeable change on the ground. So it takes a lot of work, but when you've got very compassionate and dedicated people who are there in research, there in government, there clinically, then together we can make a difference for sure.
Thank you. So we talked about ongoing relationships and involvement in various stages of a research process from your example, Isabelle. And Pam, you mentioned something about the dedication of the people involved to working together. Howard, would you like to add something to this? How does it look when it's successful, this kind of collaboration?
So hi, everybody. So I have the advantage of coming at the end. So everybody has said, I think, the essential elements. I think what's interesting is we've moved from a formal relationship where basically we put the ministry's names, in our application, so it would help our application, but really didn't engage in a relationship, to really real relationships over time. And I think one of the essential elements and difficulties is being able to respect each other's realities. and each other's how should I put it, facilitating factors, also each other's barriers, and the way we work in different ways with different objectives. So it's not always overlapping, and we have to find the overlapping areas. So we think as researchers, I've been on all 6 sides of the table, research and policy and clinical, caregiver, I suppose, as well. So I'm trying to think of the 6 sides, but there's 2 more, I'm sure. But I think what's interesting, and I think Pamela brought it up, is the reality is very different for each stakeholder. I'll use that word. I don't like it, for each stakeholder. What's important to somebody living with dementia and their caregiver may not be that important to a ministry person who's really concerned about how the emergency room is being overwhelmed and wants data on that. And what may be important to the ministry person may not be important to the clinician, and they're not bringing policy into how we're going to bring that into the real world of the clinician. So seizing all these different realities is really the challenge that we had. And we have some, I think, positive experience that I think 2 times we brought together from 3 provinces, people representing all those 6 parts of the reality. We talked about building relationship over time. I think that's, we have to be patient. And I think we also have to be prepared, each of us, to step up to the plate when needed. So researchers and clinicians participating in consultative bodies that the ministry set up, and spending time in these meetings, which is not research directly related, is very important. Ministry people participating in some of the research discussions, which may not be related directly to them, is also very important. So stepping up to the plate together, but in the end is working to understand each other's realities, each other's objectives, each other's constraints, I think is extremely important.
Thank you. So you really led us into sort of the next part of the discussion, where we want to focus on what are some of the barriers and facilitators, and maybe start a little bit with the challenges. It sounds great. It sounds wonderful to have these kinds of really deep, long-term kind of collaborations, but what makes it so hard? Pam, would you like to start?
Sure. Thank you. So I think one of the things that strikes me that makes this challenging sometimes is that faces and people change. And for meaningful collaborations, you kind of need a history, and because it's a long story and it's a complicated one. And people are coming in and out at different parts of the story. And so all the things that Howard talked about that are important kind of get lost in the shuffle a little bit. What struck me when I was working with government and working with the public service is incredibly devoted people, incredibly devoted, who want exactly what all of us want. The challenge is how do you make that happen? How do they get the right information? And they have access to different information than the researchers have access to, and they don't always have access to the scientific literature and the knowledge that brings and what it means in government. And then when you have so much changing, so many people changing, particularly in government, going from department to department, jobs being assigned, different people, it's really challenging to keep that going. So you need some strong, a strong government priority to start with, to say, this is important and we're going to do something. And then they need to assign a key leader who's going to help see this through and then connect the researchers and the clinicians. The thing about researchers and clinicians, by and large, at least in medicine, most of us are pretty static, in the sense that if we're interested in dementia now, we are going to be 5 years from now. whereas in other professions, they're in and out constantly. So you need a core group that are going to lead the charge and work together. And I think that's a good step forward. And my last point is, what strikes me through my career has been, I'll go to CFHI meetings, I'll go to policy meetings, I'll go to geriatric medicine meetings, I'll go to government meetings, and guess what? We're all talking about the same thing. It's just from different perspectives. And when you're at those meetings, you only hear one side of the six-sided story. And we really, really need to work on meetings such as this that can bring a diverse audience so that people can see all the different faces of that cube. And then I think we can work together really well. So those are my thoughts.
Thank you. Ginny, would you like to follow up on that?
Sure. So talking about some of the challenges and facilitators here. So one of our challenges is in government. Our focus is on providing good service to people. So here in the Ministry of Health, that's around healthcare. And so we go through various policy cycles, which involve various issues coming to the forefront through a variety of means, which can involve our relationship with researchers, which is important, but it also involves what's coming forward from the public. What are ministers getting calls about or getting questions about? And that leads to them wanting more information from us at the ministry. So then we have a time limit around, we have to gather some information on a particular subject. And so it's really important to have that pre-established relationship. Otherwise, we're kind of just struggling around who should we consult with. You know, if we already had a long-term relationship, it's much easier to be able to know who to draw on when you need information about a particular subject. And then when you look at from the researcher perspective, you know, they're usually interested in getting grant proposals approved and, you know, and then having successful research that actually addresses problems that people view from problems widely, not just the researcher, but a lot of people recognize it's an issue. So we're addressing a common issue. So that being engaged at the front end of research is really helpful. So as Howard mentioned, I think in the actual development of what is the issue, what are the research questions, what's really important today, that's a very helpful point to be engaged rather than at the end. And so yeah, in some kind of the barriers and facilitators are around our different perspectives, our objectives, our previous linkages, any of those things.
Mm-hmm. Thank you. Isabelle, would you like to continue on this, on barriers and facilitators?
Yeah, I completely agree with what has been said before. And I would add that one of the barriers is really one of the challenge is for researchers to develop practical recommendations, because sometimes we stop in terms of our research need, we stop at providing evidence. So for instance, quite recently, one of our PhD students, Claire Godard-Sébiot, showed that if you increase continuity of care with the same family physician, so if people see their family physician regularly, they will not go to emergency department and they will not be hospitalized. So we will decrease emergency department visit and hospitalization. That was a huge results in our research world, because you know that a person living with dementia use twice emergency departments and hospitalization, and part of that can be prevented or avoided. So here we have a piece of information that is key. One way to decrease overcrowded emergency department or hospitalization is really to increase contact with primary care services, and in particular family physician, nurses and social worker working in primary care. But then when you have said that, the next question is how to increase continuity of care with a family physician, nurses, social worker in family medicine groups, for instance. And this is where we do not have access to sometimes data to show that. But we need to work with decision maker, policy maker, clinicians, person living with dementia, care partners on providing practical recommendation. So should we have like biannual visit to family physician that is like kind of mandatory? Should we increase awareness in the public about the role of family physician and family medicine groups? So that's where we need to work together and complement with additional methods sometimes. So for instance, we can do a qualitative study to really dig deeper and understand how to increase continuity of care with a family physician. So that's part of the equation. And another challenge is really to have a recognition in our own career about the importance of this collaboration. For instance, from the point of view of researcher, it's really publish or perish and get grants and get publication and teach a number of hours per year. But the recognition about fully engage with on a long-term relationship with government and take time, as Pam said, to go to various meetings and be present, and it takes a lot of time to develop this trusty relationship, long-term relationship. And it's not well recognized in our research career. So that's an important challenge that we need to address. And I guess it's the same for people who are in government. When they attend research meetings, is it recognized in their career as something that is of value or not?
Ginny, is it?
Well, you know, we consider it valuable when we're able to attend, but yeah, if there are some other priorities coming up, sometimes that may fall off in terms of not making the priority list.
So that's something on the maybe on the system level on both sides. It needs to be acknowledged as an important thing. So one last follow-up question before we go into the breakout rooms. We have a few minutes. I just wanted you to comment or share from your experience. How do you think, you all alluded to this in your answers, that there are some differences in process of work, and we discussed this, that there are also differences in time frame of the work within government and within research. And how can we create a balance between the two different work processes to allow for an optimal collaboration? And I'm going to turn to Howard to start us with that one. You're muted, sorry.
My audio shut off just for a second. Could you just repeat the question?
Yeah, so I'm asking about how we can balance or bridge the difference in work processes between government and research. So work process and time frame.
I suppose if I really knew the answer to that question, but I just want to maybe draw from some experience in a few major projects I was involved in, and it's linked to the issue that Pam brought up of sometimes the fleeting nature of some of our relationships because people change, etc. And you know, in Quebec, we had a very interesting experience with the Quebec Alzheimer Plan and the implementation of the plan, which didn't depend upon one person or another, either in the ministry or in the clinical world or in the research world. And it's because there was an implementation plan that was set up, number one. and with specific phases and specific working groups or advisory groups, which brought together the ministry people, clinicians. We forgot managers, by the way, very important. And researchers and people with dementia, etc. So, in other words, there was a stable body that was independent of the particularly ministry person, for example, that was in charge. In fact, we've gone through, now we're on to our third ministry person, and we've been able to maintain a certain continuity. So that would be my answer to how we maintain processes. And I had the same experience in another major project in a previous life, the SEPA project, where there were regular meetings between the researchers, the clinicians, the managers, the decision makers, regular meetings that were able to exchange and influence the course and adjust on what we were doing.
Thank you. Ginny, would you like to add on this from your perspective quickly?
Oh, sure. So I think it's really important to make attempts to understand one another's perspectives and to try to see how you can bring value to that. So by the radar group understanding the perspective of government needing to provide good services to people, they make sure to always highlight the good service they are providing through their projects that they do and how they are extending various services to remote and rural locations. And it really does bring value to what we do. And we really appreciate that. And then from our perspective, I really try to understand the researchers' need to be able to write successful grants, to do publications and such. And so whenever they reach out to ask for some input on something, I give that my priority as well. So I think responding to each other's priorities and perspectives really helps.
Thank you. So Howard talked about putting in place some processes and expectations and plans that everybody can follow and participate in a way that is good for them. And Ginny, you talked about being able to take each other's perspective. Pam, would you like to add to that? You're muted.
Sure. Yes, thank you. I think those are very valuable points. And I'll give you another example similar to Howard's that's ongoing in New Brunswick right now. So New Brunswick was fortunate to be able to receive a grant from PHAC for Healthy Seniors pilot projects to look at ways of implementing knowledge research in a way that's clinically important to promote health in seniors. So a very broad mandate. But it has brought together government, two different departments of government, researchers, clinicians, business community, private sector, public sector, to come together to use some of the traditional research methods, but in a more translational way, in a meaningful way. And there's, as Howard illustrated, there's a monitoring process, and there's an implementation plan, and there's check marks and checkpoints along the way to make sure everyone's staying on track. So while it's hard for everybody to kind of learn how to do this all together, I think it's actually very effective. We're pretty early on in this, but so far so good. And I think in the end, it will be helpful. And the goal is to produce results that are clinically meaningful that can then be translated into other parts of Canada. It's not just meant to be for the betterment of care in New Brunswick, but how do we implement and upscale and these projects elsewhere? So good example, Howard, and I think that that's the way to go to deal with all the changing people. We have a plan so that it works. Thank you.
Thank you. Isabelle, anything to add before we move on?
Yes, maybe I can comment a little bit on the time frame, because I think it's important to acknowledge that we have different time frame to start with. and to find a balance between the best method in the world and the need to provide results, timely results. So how we manage that? Because the researcher want to use the best method, and that's perfectly fine. And the decision maker needs timely results. So, and to use the best methods, usually it takes more time, you know. So how we manage that in our team is we try to do both. For instance, we provide results as soon as they are available. They might not be the final one, but we can provide preliminary results, descriptive statistic about who are the person who died from COVID in the dementia population, for instance. Are there more the racialized person with low socioeconomic status? It might not be the best results in the end, research results in the end, but for decision maker and policy maker, it's better to take action on preliminary results and on some sort of evidence rather than taking action without any evidence. And then in parallel to that, we continue the research process, and we use more advanced method to really capture, understand what are the impact of COVID, what are the most vulnerable population among the person with dementia. Is it better to stay at home or not, for instance? And then we have more refined and more, I would say, complex results to show, but it takes a longer time.
Thank you. So thank you for this rich discussion, and especially all the examples, because they're very telling about what's difficult in this type of academia and government collaboration, and what's and what are maybe some interesting ways to do it and to bridge the differences. We're gonna move now to the breakout rooms. I'll remind you now, and you can mention it again in the rooms themselves. What we're gonna do in the breakout rooms is try to come up in small group discussions with some guiding principles. Based on this discussion and based on the experience that our participants are bringing to the table, what are some principles that can guide effective government academia collaboration? So we're ready to move to the breakout rooms. Charles. Oh, Pam is there. Okay, didn't see her. Hi, Pam. You're welcome to turn on the camera if you'd like. So I think that's all of us. A lot of people have left when we started the breakout room, but I'm thankful for those of you who stayed with us.
I told you, Inbal, we should have served coffee and you know, fruit.
Yeah,
that would have helped keep people. That would have helped keep people.
It's all about the croissants. Well, so thank you for those of you who stayed with us for the discussion. It was nice to have a small group and be able to really hear from people's different perspective. So just to summarize, I want to take a few minutes to see what was in the discussion in different breakout rooms, if you were able to come up with any principles or new points that were not mentioned in the discussion. Ginny, from your group, if there are participants here, you're welcome to also turn on your microphone and share with us from your discussion in the group.
CAHS was going to be reporting from our group.
Yeah, so essentially I broke it. We had a nice discussion. It was a small group, but I think we had a couple points. They're not specifically principles, but they're more just like thoughts that we had. So the first one was just to recognize each other's needs, specifically between academia and the government. And a part of that is like researchers like to have stable funding environments. So if there was a way to provide even like small amounts, this would create long-term relationships where that there is stable funding and allow the researchers to apply for larger grants. On top of that, we reiterated what was said earlier with being respectful of different timelines. Governments sometimes work on a shorter timeline. Researchers want to do the complete process. And you both need to understand each other's timelines. A big one that we had was that when doing collaborations, you have to collaborate as early in the process as possible. and also engage all the stakeholders and groups, which includes patients, users, different communities. This really leads to an alignment of research questions and policy questions, and it makes a meaningful collaboration that has better outcomes for not only the government and the academics, but also the communities and the users that are going to be using the products and the outcomes of the research. And the final thing was was that maybe there should be more training on how to do collaborations, and specifically with different frameworks of approaching collaborations with different groups. Different groups often have different ways of looking at questions, different worldviews, and even different ways of using the language. And so there isn't a lot of training on how to approach how to even start collaborating with other people. And we think that would help increase understanding and just in general make the research outcomes more applicable.
Mm-hmm.
So that's it from us.
Thank you. Isabelle and Pam, you were in the same group?
Pam will provide a perfect summary.
Thanks, Isabelle. So it was Isabelle and I and S. Malik and Naomi. We had a great discussion, and I think we've sort of come up with 4, I would say, ideas or principles, and much of which has just been covered. But I like the point about teaching each other how to collaborate. I think that is missing in many of our training, much of our training. So I think that's very important. So the first one was about effective communication, both ways. And the examples that were described were when researchers are presenting information to bureaucrats, short messages. It improved patient satisfaction. It decreased hospital admissions. And don't get into all the specific methodological challenges that we spend hours debating. They rely on us as researchers to have those discussions behind the scenes to make sure that the methods are as sound as they can be. So to give those messages short, succinctly, and in the way of infographics are very, very valuable. The other key part in this is know who your audience is. And this isn't new information, but the amount of information that can go to bureaucrats is more and probably a little more complicated than can go to the political people. And as Isabelle said, we need to rely on the bureaucrats to communicate to the politicians, because the message needs to be very simple to the politicians. And most of the time as researchers, we don't really engage purposefully with the politicians. We don't go seek out a meeting with the researcher, with the health minister, but the door is always open for the researcher to come and speak with the health minister if invited. But we don't want to be seen as going directly to the political side. So we rely on the bureaucrats to be our conduit, but we're always available for those discussions if needed. So effective communication in a way that is meaningful for government. The other principle was two-way communication, and that is government also communicating with the researchers in terms of what they see as priorities that are upcoming. Isabelle gave another example of sitting on key government committees with a standing agenda item to discuss research, so that she hears what's being discussed at the meeting, understands what's coming. She's able to provide information about results from research, but also able to bring to the table, there's some opportunities that may be coming funding wise. How does this align with government priorities? So instead of relying on an invitation every time to come and talk, asking for those people to be sitting at the table on a regular basis, and for the researchers or academics to be present at those meetings and prioritizing. And I think many of us would absolutely welcome that opportunity. The other principle is flexibility on behalf of the researchers. So Most of us are used to, you know, a well thought out research question with all the, you know, perfect methodological ways to answer the question, and try and be as pure scientifically as we can. But sometimes government doesn't need that or want that, and they actually need a project done very quickly. And Isabelle gave an example in COVID, where government asked her if she could help with this certain project. Well, it doesn't fit, you know, perfectly into a research bucket. It is very meaningful and very needed for government and very practical. And for us as researchers to be willing to think outside of our perfect worlds, and as perfect, you know, as imperfect as they are, but to take on willingly those projects and to adapt so that we can provide useful information back. So being flexible with government. And the last one was what we've talked about and was raised is early engagement, and right from the get-go, and not, if you're thinking of applying for a grant, start the conversations then. Don't send the first communication about this grant the week before the letter of support is due from government, because it's too much pressure on government to move it through their channels to get the signature. They want to be part of this. They want to be part of good science and moving forward, but they need to be able to move things through their channels in a meaningful way too. And a week's turnaround, as Ginny would know, is a pretty miraculous ask. So it needs to come with lots of time and ability to provide meaningful input. So those were the four: effective communication, two-way communication, flexibility, and early engagement.
Can I suggest another one?
Sure.
Patience.
Patience, yes.
Yes. Sometimes researchers, we get results, we think they're fantastic, and we'd like to see changes in the healthcare system, but sometimes it takes time.
Yeah.
And you have to be very patient.
Yeah.
Sometimes you'll see the results in terms of government policy, maybe 2 or 3 or 4 years down the line.
Right. Exactly. Excellent point. Isabelle, did you want to add, or Malik, did you want to add? Okay.
So in our group, we were only 3 groups in the end. We consolidated. We also talked about early engagement. Andrew was able to share an example from a different context with involving opinion key leaders and researchers. I don't know, Andrew, if there was something specific from that part of the conversation that you wanted to highlight.
Just that, it depends on the topic. It's also leveraging international organizations. In our case, it's OECD. So, that was an opportunity for an international body to then reach out to member states. And within Canada, we reached out to our some select opinion leaders to help formulate some principles on responsible innovation in neurotechnology. So, that was a very, that was a fairly seamless exercise, but I think the challenge will come, as I mentioned, as we roll out those principles and see how the uptake is with the broader science research community.
Right. So leveraging international organizations was an important principle in your case, and maybe in general, we all talked about this even before, the engagement of different stakeholders and bringing everybody to the table, which was one of the main things we talked about in our group. I hope I'm quoting this correctly, but I think it was Patrick who said something like the perfect scientific answer will rarely translate to the perfect policy. And then Howard added to that it will rarely translate into the perfect practice or implementation situation. So the principle we came up with from that conversation was that research policy and practice need to be a continuous communication cycle that sort of keeps feeding the process in an iterative way to make sure that the end result of an implementation of a policy really happens and happens optimally. How would you want to add on this?
Yeah, just to say, the notion from research to policy to practice, or research to policy to implementation and back again. And just to draw on practical experience, that is what has happened with the implementation of the Quebec Alzheimer Plan. There was the plan that was published, and the government said, okay, we want to implement it. It was the first that Isabelle was involved in, a first quick and dirty research project that wasn't that dirty, wasn't that quick, but fairly quick, actually within several months. And then there was implementation with evaluation of the first phase. And then the second phase based on the results of the first phase. There was work then with clinicians to develop practice guidelines and practice trajectories. And then back again to prepare for the third phase. So it's actually quite interesting if you think of it that way. And it's a continuous development cycle.
Mm-hmm. Continuous development cycle. Thank you. Is anybody who's present from the panelists or the participants would like to add anything that they want to highlight as a principle that could be useful?
If I could add
just
one
comment, we were lucky to have S. Malik in our group, and he's a neuroscientist working in government. So I was thinking that maybe we should find a way to use this type of person who have one foot in government and 1 foot in research or science, because they can be knowledge broker, and they can be championing some research results and help us develop an appropriate communication package for the public. Or I think it can be, as you mentioned, training how to better collaborate together and use this type of person who are both scientists and government officers can be a good strategy.
Mm-hmm. Thank you.
And if I can add one more thing, and Isabelle and I worked together for so long, we think the same way. So I was going to add to that, and I was going to add in, and we mentioned this a little earlier, is the importance of the clinical leadership at the very beginning of all this. Because if we leave the discussions only at the research and policy level, we've actually missed out how to practically roll out this policy. And I see Howard shaking his head because he's used to being the clinician too, and
nodding my head.
Nodding, yeah, exactly, nodding your head. And sometimes we can think we've done a great job, but if the clinicians go, "What are you talking about?"
Yeah,
it is going to remain a report on a desk, and they're not going to implement. And so they need to have input, and even having managers, clinical managers at tables is helpful. But if they don't have a good relationship with the frontline staff, we're not going to get effective change at the front line. So somehow having those clinical leaders that are going to help, once the evidence is there, once the knowledge is there, the actual implementation science of this, and they need to be part of this equation, I think.
Thank you. Before we move to just last comments, I wanted to mention that for those of you who stayed with us until this point, if anybody is interested, we're going to try to put together this list of principles and perhaps publish or share it in some way with researchers and government people who can benefit from this thought process, this exercise that we did here. So if anybody's interested in participating in putting this list together, Naomi is going to put my contact in the chat, and you can email me and connect about that. Ginny or Howard, do you have anything else to add on the principles that were just summarized?
I would just say that I really appreciate Pam's recent comment there about making sure that we involve all the groups in the process to develop the right research question and move forward on relevant research that's going to address real needs, like right from the patient, client, or user to the clinicians to clinical managers to government and researchers. We all hold pieces of the puzzle, and we need to find the ways to work together.
So if I could just say, I think what Ginny just said and what Pam just said was sort of confirms this idea of this cycle from well, you can start anywhere. Like you start from practice to research to policy and back again. We need those. That cycle has to continue. That has to be continuous. And if each piece is not involved, nothing's going to happen. If the clinicians are involved, but they don't get the researchers and the policymakers, the clinicians have a great idea, a great innovation, but it could be like a tree falling in a forest where nobody's there. So the importance of research and getting out the ideas and then to policy. So I think this circle, this continuous circle is extremely important as a concept.
Exactly. And letting the clinicians feed back what worked and what didn't work so that you can continue to constantly adjust. And it takes work, but I think it's well worth it.
Yeah. And Pam, you and I both know the vast amount of clinical guidelines that nobody really looks at.
Exactly.
Because nobody's thought of how that would land in a practice.
Yeah, that's right. Exactly.
That's a perfect example, I think, of
brilliant example. And it's very hard to pick up. I feel for the family doctors who have to deal with all these guidelines across all ages and all diseases. I don't know how they can possibly manage it.
Yeah.
Yeah.
And I think particularly with dementia, there seems to be a lot of concern about guidelines. And my point of view is the guidelines aren't the problem. We have guidelines, they're not going to change, they haven't changed that much. The guidelines aren't the problem. The problem is the implementation. The problem is how does it land in a busy primary care practice? And so what we should be working on is clinical pathways.
Yeah, exactly.
Thank you. Is any one of our participants interested in sharing last thoughts? Okay, I thank all of you for your participation, and I thank our panelists so much for really an interesting conversation that has a lot of potential to really help build future relationships in a way that's really meaningful all the way to the implementation, as we were just discussing. So thank you all for joining us, and thank you CSPC for the organization, and I hope you enjoy the rest of the conference.
Thank you, and thank you, Inbal. Thanks, everybody.
Thanks.
Bye-bye.
Bye-bye.
Bye.